Thank you all for joining us for this academic symposium to explore some of the ethical issues raised by the work of this year's Inamori Ethics Prize recipient, Mr. Stan Brock, and the challenges he faces as the leader of a nonprofit organization dedicated to providing free health care services in this country and all around the world. Hopefully many of you were able to attend the prize ceremony earlier today and listen to Mr. Brock's remarks on health care and learn about his work with remote area medical. It was a very enlightening and inspirational presentation. It was one of those that makes me wonder why I have had such a boring life. At the age of 16, Stan Brock decided to leave his birthplace in England and join his parents in Guyana to help local populations improving their living conditions. He spent the next 15 years of his life living in the central Amazon basin with the Wapishana Indians. While there, he survived malaria, dengue fever, animal attacks, and several near-death experiences, one of which he described earlier today, if you weren't there. Astonishingly, he lived through all these ordeals without the assistance of a physician, as the nearest one was 26 days away from the village where he lived. Mr. Brock's experiences inspired him to design an all-volunteer program that would deliver free health care services across the world. That program is Remote Area Medical. While originally conceived as a means to provide care in remote areas, developing countries, and sites of natural disasters, RAM now provides the majority of its care in the United States. From Appalachia to urban Los Angeles, over the past 25 years, RAM has helped nearly 500,000 people and provided millions of dollars in free health care. Joining Stan Brock on our panel today are Professors Jessica Berg, Insu Hewan from Case Western Reserve University, and Danny Williams from the Cleveland Free Clinic. Jessica Berg is Professor of Law, Bioethics, and Epidemiology and Biostatistics. She received both her BA and JD from Cornell University and her MPH from Case Western Reserve University School of Medicine. Ms. Berg joined the faculty at Case Western in 1999 after teaching at the University of Chicago Law School and Northwestern University Law School. Before that, she was a visiting professor at Michigan State Medical School, a scholar in excellence at the University of Massachusetts Medical School, and a fellow at both the Center for Biomedical Ethics and the Institute for Law, Psychiatry, and Public Policy at the University of Virginia. Ms. Berg teaches health policy, bioethics and law, food and drug law, public health law and ethics, research law and regulation, reproduction law, and scientific integrity. They obviously keep you very busy at the law school. She is the first author on a book published by Oxford University Press entitled Informed Consent, Legal Theory and Clinical Practice. Ms. Berg is the legal consultant for the American Academy of Pediatrics Committee on Bioethics. In addition, she is on the editorial board of the American Journal of Bioethics. In 2008, Ms. Berg was named Health Policy Researcher of the Year by the Health Policy Institute of Ohio. And in 2009, she received the Mather Spotlight Award for Excellence in Research. Insu Hewan is Associate Professor in the Department of Bioethics and Director of the Stem Cell Ethics Center at Case Western Reserve University. He received his BA and MA in philosophy at Stanford University and his PhD in philosophy at Brown University. His research interests include ethical and policy issues in stem cell research, social justice, medical decision-making, and health resource allocation. In 2005, he was awarded a Fulbright Research Award by the U.S. Department of State to study the ethical, legal, and cultural dynamics of human research cloning in South Korea. In 2006, he chaired the Subcommittee on Human Biological Materials Procurement for the International Embryonic Stem Cell Guidelines Task Force, a multinational, multidisciplinary working group for the ISSCR, which is the International Society for Stem Cell Research. In 2007, he served as co-chairman of the ISSCR Task Force on International Guidelines for the Clinical Translation of Stem Cells. He is past chairperson of the ISSCR's Ethics and Public Policy Committee. Dr. Hewan's articles have appeared in many peer-reviewed journals, including Science, Nature, Cell, the Hastings Center Report, and the Kennedy Institute Ethics Journal. Danny R. Williams has spent his professional career serving the greater community as a practicing attorney, public official, and nonprofit executive. He earned his BA from Princeton, JD from the University of Michigan, and MA from Case Western Reserve University. Following a successful legal career, Danny served as Cleveland's law director in Mayor Michael R. White's administration, and later as Cuyahoga County administrator, before assuming leadership positions in the nonprofit sector. He has been the executive director and director of the local chapter of the American Cancer Society, CEO of the Greater Cleveland Roundtable, a social justice advocacy organization, and senior VP and general counsel of the Greater Cleveland Partnership, Cleveland's Chamber of Commerce. Since 2006, he has served as executive director of the Free Medical Clinic of Greater Cleveland, an Ohio nonprofit that provides medical, dental, behavioral health, and HIV/AIDS services to more than 10,000 uninsured and medically underserved patients each year in the community. We hope you will take this opportunity to listen and engage with all of our panelists on issues of ethics and social justice that concern us all. I will now turn the podium over to Shannon F.E. French, the Inamori Professor of Ethics and Director of the Inamori International Center for Ethics and Excellence, who will moderate our discussion. Thank you.
Thank you so much, Provost Basilick, President Snyder, and honored guests. Thank you all for coming, and I would tell you that this symposium will be one where we hope you will all engage with all of our panelists, and therefore we have set up a microphone there in the middle of the aisle so that we can all hear you clearly when you have questions. I'm going to start the ball rolling with Stan Brock and our three panelists, but then we will open the floor, so if you want to have questions forming in your minds for that moment. So as an opening question, and I pose this to all of you, and we'll see who would care to dive in first. I have been wondering, do different ethical considerations arise when you're trying to deliver free health care in different settings? For example, an urban setting versus a rural one, or a developed country versus a developing one, or the site of a disaster. I know obviously the logistics must vary in those different situations, but what I'm asking here is whether the ethical issues are different as well. Would anyone like to start with that one?
Well, I certainly haven't noticed any in our delivery of our type of health care. The patients that come to our events are from all walks of life. And some of them are very well dressed. Some of them are driving expensive automobiles or motorcycles. And some of them are homeless. So it's all across the spectrum. And we certainly don't ask many questions because, other than where does it hurt, because they're obviously there for some reason, despite the fact that they may have on a nice a suit of clothes or be driving an upscale vehicle. We do not know what pressures are upon them in their everyday lives, what misfortunes have befell them. What we do know is that they've all been out there for many, many hours, because in order to get service at one of our events, unfortunately, you better be there either before midnight or very shortly thereafter in order to get a number. And so anybody that's willing and has the intestinal fortitude to endure that kind of a wait deserves whatever we can do for them. But I have never noticed any ethical differences in the profile of our patients.
Would any of the other panelists care to comment?
I'll jump in on that. So I'm not sure if there are differences in the patients, but I do think there are some differences in the considerations you have if you're in a very resource-poor country. I think there are genuine questions about what kinds of things you should be offering that you know that they will not have access to in follow-up care, for example. I think there are genuine questions about where you should be spending time and resources based on overall needs in the country versus the individuals in front of you. And there are people who've come who, do disaster care medicine, for example, who run into situations where they get to the country with a lot of, great technology, intending to use it, and the response back, which I'm sure you're very familiar with when you say, everybody really needs their basic dental and vision care before we even go the next step. The response back from the people in the country is, that's great, I'm so glad you brought that stuff, that's not what we need. We need basic ways to get clean water. So can you help us with that while you're here? We need, or if you talk to people who went on the ship Mercy for the tsunami, a number of people, a number of physicians who went on the trip thinking that what they really had to deal with were sort of, immediate issues of, serious medical care, found that there were some really basic primary care needs that just were not being met in the country they came into. So it's not clear. It raises just some interesting questions about the extent to which we have very significant differences in the allocation of resources, both within this country and certainly between this country and other countries, and what kinds of ways we're supposed to help.
Danny.
I would add to that, and you remind me, Jessica, when you talk, is this on? I think it's on. When you talk about whether or not there ought to be adaptability, whether or not you even should ask the question. A few years after I got out of law school, I remember there was a huge debate over whether or not there should be a boycott of Nestle. You recall, because of the baby formula issue, where they were sending baby formula to places where they didn't have clean water, and where there wasn't a literacy level that allowed the mothers to be able to, to use it properly. Sometimes they were diluting it and so forth. And so I think to me, it almost goes without saying you ought to ask the question. The answer is not a given, but when you go from one location to the next, I'm not sure that one size fits all. So I would start with that. And I guess the other thing is, I would say that while it may not be the obligation for the provider, the great stuff that Mr. Brock's been doing may not necessarily be an obligation on his part to try to do more, but it may be on the other institutions in that environment. So if you go to a place that is rich in resources, I could see an argument that it's unethical to not ask those other institutions to participate in what's going on. I mean, so if you're in the middle of nowhere and there aren't hospitals around, they're 26 miles away, who can you ask to do anything? But if you're let's say you're in the middle of Cleveland, I mean, and we've in fact we've done
sirens going by.
Well, we've done an event in Cleveland that was inspired by your work. The Free Clinic did in collaboration with MedWorks, and one of the things that I insisted on for us to be involved was that we did bring in the other institutions, because it didn't seem appropriate in an environment like Cleveland to do something like this for a few days and then leave people with no options for follow-up care. That in this city, in this context, I felt that was unethical. If you're in the middle of nowhere, it's a different issue. But I don't think it's appropriate when you're in an urban environment rich with resources to parachute in and not insist that those institutions pick up the ball in some manner after you're gone.
So just to follow up, so did you work with university hospitals and or the Cleveland Clinic? What did you insist on from them?
My ideal world would have been that we got commitments for X number of slots. All right, we'll take 10 cardiac patients. The timing wasn't right to try to make that happen, but at a minimum, they were there, they showed up, they had their folks who were knowledgeable about their charity care programs, they're signing people up on site. We had social workers who could help kind of get people to other resources. So it was an effort to at least make sure that people had real connections before they left that day to other institutions that could help them. And it seemed to me that was the least we could do in a place like Cleveland.
Stan, would you like to comment at all on the follow-on care that might happen for people who come to a RAM clinic? You were saying in your remarks earlier that some of the people that you see didn't even know they had diabetes or other long-term health concerns. Is there anything you can do, at least in some of the settings that you go to try to ensure that they do get that follow-on care, or is that beyond your scope?
No, it's something that we really pay a lot of attention to. It is also the major challenge. Those people that come, even people that require and get a full mouth extraction where you remove all 32 teeth, or they get a pair of eyeglasses, unless they've got glaucoma or the need for cataract surgery, basically that one event has taken care of that problem for them. And the percentage of problems developing out of full mouth extractions or multiple extractions are really very few. And my colleague, Dr. John Osborne, the director of our dental department, of course, could address that issue much better than I. But we do, of course, discover a lot of people. And I had a patient come up to me 2 weeks ago at one of our other events in Appalachia and say that this particular RAM event that he'd come to on 2 or 3 occasions over a period of 2 years had, as he said, saved his life, because he didn't know he had diabetes, he didn't know he had hypertension, and we were able to channel him to some follow-up facilities. But it's difficult. It really is a great challenge. And, you know, I've had, I remember one dentist, and I'm not singling out dentists, and I know that, that Dr. Osborne would agree with this. We had a dentist that came to us regularly. He's now deceased. I hope not as a result of his volunteer work. But we had this dentist that would come to all of our clinics, and he said, I don't want to see these people in my office. I don't mind seeing them here at the RAM event, but I don't want to see them in my office.
What did he mean by that?
Well, he just didn't want to find every day 2 or 3 people that outside his door that were looking for charity care. And if his thought was, once I start doing this at my office, they're going to keep coming and they're going to tell their friends, and it'll be a real problem for my business. So he, from his perspective, if it's a part of the ethical issue, I'm going to go out and do it at one of these organized events, so I don't have to do it in my office.
Day to day.
Yeah.
Interesting.
And but the follow-up issue is a problem, and one area where we really pay a lot of attention to it, and rightly should, are in the cases of the women's health, where we've done pap smears or mammograms, where you absolutely have to be 100% sure that you're going to be able to track those patients and give them the results, good, bad, or bad, and if in the case of bad, make sure that they get some follow-up care. Once you've committed to providing the care for the patient in a life and death situation, potentially, you're then obligated really to follow it up. And you know what? Sometimes those people drop through the cracks too. Paperwork gets lost. They don't give us the correct address of where they live, and we can't contact them. So it is a problem.
Insu.
I just want to follow up and maybe to clarify something you've said. So do you mean to say that not partnering up with local urban health institutions is ethically wrong, or just not politically correct? It's not politic. Did you mean something more than just you might upset the folks who are healthcare providers in the urban area, or just that?
Well, I guess what I'm suggesting, you have to understand that at the Free Clinic, we've got a twofold mission. One is to, care for people day to day who need, care in a broad range of areas. But the other is to advocate for policy changes that make healthcare available to everybody. So it's it's part of our DNA. So what I was suggesting is I believe, not just personally, but based on the ethic of the institution that I represent, that we should be pushing for institutions to broaden their policies that would open the doors more for charity care. Figure out a way to absorb it. I mean, there's an effort underway locally called CHAP, Cuyahoga Health Access Partnership, I believe. That's what the P stands for. And the goal of CHAP is to try to figure out how to more equitably distribute those patients that would qualify for charity care, because some have argued that they're inordinately being funneled one place or another, and it would seem to us that we have enough resources that we could do a much better job of absorbing this. So I guess I'm just suggesting that we ought to aspire to a higher level of ethical compliance by suggesting that when we engage in this, we go beyond the minimum, and we try to make sure that we be an example for others to follow in terms of recruiting institutions that have the capacity to participate as partners.
So you're wanting to build more into the system so that the same number of people who aren't getting health care doesn't change, doesn't stay the same, rather, from year to year, but does actually reduce because they're taking in more charity patients.
I'm not sure that's a high enough bar. If it were left to me, I think we need to change the definition of who our neighbor is. What I find is that people will find ways to find access for folks who they view as similar to themselves. And the more dissimilar they view those people from themselves, the less, urgent that need is going to be. So I think we need to broaden the definition of who we think deserves the same care as my brother deserves and my mother deserves. That would be my aspiration.
Well, let me ask a related question then, again, to all of you, which is there any concern in any of your minds that providing free health care, whether it's through a program like Remote Area Medical or the Free Clinic in any other potential program, might these somehow, certainly unintentionally, delay the development of systems to deliver quality health care for all? In other words, what I'm worried about here is by treating the symptom, is it possible that you might unintentionally obstruct the search for a cure for the underlying disease because people will say, well, someone is handling that this need is being met, not by me, but this need is being met somewhere, and therefore I don't feel the same urgency to do anything about it. Now, it wouldn't be, a fault. You still have good reasons to provide the care. But does anyone have that worry that this is a way to make people feel good when they should feel the urgency?
Well, I'll start. If I'm understanding your question, it's almost as if, is this an escape valve that takes the pressure off?
Yeah.
And it may be to some degree, but the only other alternative is you use people as props, and you say, well, all right, well, I'm not going to care for you because by caring for you, I'm going to take the pressure off and make people feel that there's less of a need. So it may well be having the effect you're suggesting, but I'm not sure that the alternative wouldn't be worse.
Stan, do you have any thoughts on this?
My only comment on that is that we have heard on several occasions over the years that certain parts of the country did not want us to be there because it might impede the possibility of them getting a grant to provide the kind of services that we were about to provide free of charge. But that has come up on 2 or 3 occasions.
I have a question for Mr. Brock. So initially, when you conceived of your organization, you thought what you would be providing is medical care for people who are too remote from medical professionals, right? So bringing the medical care to the people who otherwise would have to travel very far. But when you do most of your care now in the United States, and let's say in urban areas, the remoteness there, this is alluded to when you had your discussion with the astronaut, the remoteness there is more socioeconomic remoteness rather than distance.
Yeah.
Now, when you went from sort of remote care in the rural sense to sort of more the urban sense and the political sense of remoteness, did you realize that you were actually doing quite a shift there in sort of the mission statement of your organization? It really kind of seemed to turn political then once you did that, once you focused on 65% or more in the U.S.
Well, I suppose there was a risk of that, but since we've been doing this for 25 years in this country, we were doing this long before it became a political issue. So I think that we can certainly discredit any inference that we are trying to make a political statement because we've been doing this for years. For example, in Washington, D.C., for at least 15 years, we've been getting requests from not from the government now, but from private organizations, whether they were civic organizations or church groups, to bring our organization into the nation's capital. But it was always blocked by the Commissioner of Health and the authorities in the district. until, in fact, October of last year, when, and this was just a follow-up of the sort of almost annual effort to hold one of these events in the nation's capital, because for 15 years or so, we've been getting these requests. And then we did get permission to hold it, but a month or two later, they changed the rules by which we were going to be able to hold it, and so we had to pull out and abandon doing it.
And that was politics intruding in that case?
That was politics intruding there, yeah, but we certainly have absolutely no political motives, and in fact I avoid commenting on whether universal health care is the way we should go, or in some other direction. That's not what we do. We are the voice, really, of the needy folks that need the care, but we're not going to use that voice in any kind of a political way at all.
Jessica, did you want to comment?
I think that, it nicely demonstrates some of the differences in, being able to offer care in a remote locale and say, it's really just an absence of care. And as, Mr. Williams points out, their goal is twofold. So as to avoid that situation where you're saying, well, all I'm doing is just meeting the need right here, is to say, I'm meeting the need and there's a genuine problem. It's a problem that we address both by bringing in organizations that are local and saying, you can't ignore this, and also by pushing hard on, on a different level, on a policy level, to say we need changes overall. So, of course there's the danger, but, historically we've also said, even in the absence of organizations like this, well, those are charity issues, the church will deal with that. Our historic hospitals were linked with religious groups, and the idea was they would provide all of your charity care. So, yes, we as, a society tend to look at other ways out, and I think if we see them, we'll say, well, somebody's dealing with that need, but that doesn't mean you can't still do that, and at the same time push hard on other levels. And maybe it's not your group that pushes, maybe it's other policy groups that push to say, this is a problem that has to be solved on a much larger scale.
Well, you've given me a lead into the last question that I wanted to ask before opening up to all of you. And it is a broader question, but it relates to everything you've been discussing so far. We know that, unfortunately, you do often have to appeal to self-interest to motivate people to do what we feel they ought to do ethically. And I was wondering if any of you would care to express the best case that you can make, that by helping people who are in the situation that they might come to a RAM clinic or they might come to the free clinic, by helping those people, we are helping all of us. Is there a way to make that case that might appeal straight to that self-interest button for people?
I can think of several. Initially, you start with the fact that if you don't care about these folks, which I really think you should.
Yes. We would prefer that be the
That would be my
reason,
first choice.
Yes.
That we're paying for this anyway. I mean, those who are uninsured, those who don't have other access, eventually show up someplace. And at least one recent study that I've seen suggests that, the average cost of a family health plan is somewhere in the neighborhood of $12,000, $13,000, and baked into that cost is about $1,000 to pay for the cost of uninsured. So, like it or not, if we don't decide that politically we're not going to come up with a solution, we'll just pay for it as part of our health premiums. So if you don't care about folks, think about your own budget. The other thing is, we're going through a transformation here in this county. We're looking at a new form of government, and a big part of what's being used as a motivation for that is we want to do a better job of economic development. Well, if people aren't in good health, they're not going to be very productive workers. Companies that are looking to relocate here are looking for a strong, productive, healthy workforce. So, again, it's in our community's best interest to field a workforce that is going to be reliable and productive. So, again, if you don't care about the people, care about economic development and what companies are looking for when they look to relocate to a region.
Would any of the rest of you care to comment on this?
Sure. There's a branch of game theory and decision-making theory and philosophy that would say that it's in your long-term self-interest to promote something like this because you never know if you would be in a position where you might need that kind of care. So it's rational in the long term for you to support something like this.
That if there's no safety net, then it's also not there for you if you might need it. Yes. Stan, have you been asked this question before, or if you'd like to comment also on how you motivate people to volunteer?
I don't know that we really, except of course at gatherings such as this, where we obviously appeal for volunteers. There's 800,000 physicians out there and 180,000 dentists, and some of them are like John Osborne here. They want to volunteer their services, so we don't actually have to put out a great deal of effort to recruit these volunteers. We're fortunate that they call us and offer their services.
Do you think that the reason that some people don't seem to care about some of these issues is simply that they're not as aware of it, so that when you have something like the 60 Minutes program that was done about RAM, it does raise people's consciousness, and people whose hearts are in the right place will then step up and support a group like RAM or volunteer? Is it just that there's a silent problem and people just don't see it every day?
Well, that's a very good question, and there's a prime example of it, without using the gentleman's name, that was focused on mightily on network television and other programs. This senior executive in one of the top 5 insurance companies in the United States, a very senior executive, happened to be driving by the Wise County, Virginia fairgrounds in his car, and he saw in this field this enormous expanse of parked vehicles and thousands of people milling around there. And so just out of curiosity, he parked his car and walked through and saw all of these thousands of people that were lined up, and 100 dental chairs there, and people getting all of their teeth pulled out, and another area where they were doing eye exams and cranking out eyeglasses, and another area where there were 150 physicians treating all manner of problems, and a big pharmacy. I think we had like $1 million worth of medications that we were prescribing. And this senior executive of this very large health insurance company got back in his car, and then he drove to the airport, and he got in the company jet, and the flight attendant, the company flight attendant, brought lunch in a nice china service with the gold around the edges. And you know what? It affected him so mightily that he resigned his position and became an advocate for the changes in the healthcare system in this country, and saying how appalling it was that the health insurance industry was doing this and doing this, of which he said, because I was on panel discussions, so to speak, with him on a couple of occasions, and he said, and I was part of the problem. He was part of the problem. And
so a true conversion story, and there's no one more passionate than the convert.
You have to see it, really. You can see it on TV, and I'm sure he'd seen it on television. He'd probably seen 60 Minutes. But there's a difference when you stand there at 5:30 in the morning and see this mass of humanity dragging oxygen bottles with them, and on wheelchairs, and it's just unbelievable. And for anybody who's actually witnessed that and seen the relief that these people have when somebody has removed the pain by extracting one tooth or 20 teeth, where they hug the doctor afterwards, and they're actually in tears. I mean, it's no wonder that insurance executive was so inspired that it has changed his whole life.
Sharon, can I just mention?
Yes, absolutely.
One additional thing. I think the lack of awareness is part of it. Mm-hmm. But there seems to be, not to get too existential about it, but it seems to be an active anti-empathy movement at play. I mean, when I was growing up, empathy was a good word. I don't think I ever heard the word used in my family, but it was certainly taught. Mm-hmm. And there seems to be an active movement. Empathy now seems to be a bad word in some circles. It was used negatively against, I remember, one of the Supreme Court nominees that when that word was used to describe her, that it was then used against her in her confirmation process. And so that's an odd development for me, but I think that also affects whether or not people look at circumstances like this and view it as a problem as opposed to a failure of that group to be more personally responsible for their circumstances.
Blaming the individuals.
Obesity is a problem in some view of a lack of personal responsibility as opposed to other factors that might have led to that person or that group not having access to healthy food. And so there seems to be a very active movement to focus much more on the personal failings that we all have, but are much more easy to point to in a group of poor people or others who don't have strong advocates. And I think that also affects why people may not be responding as actively as they might.
You know, following on what you say was absolutely true. You know, a lot of this stuff appears on blogs, right?
Of course.
And then,
well, with the anonymity of the internet, people feel free to say.
And then you have strings of comments from the public, and I get to read some of those or scan some of them. They are overwhelmingly compassionate in their comment, but now and then you'll see some that say, "Why don't those deadbeat people get a job?" You know, but generally speaking, the public seem to be very compassionate and show empathy for these people who are in this unfortunate situation.
Well, now I would like to open the floor, and when you have a question, if you could make your way to our mic. I know it's a little uncomfortable to have to work your way through the aisle, but because of our recording, it's very helpful if we can have you with the amplification. So please, your question, and if you could say to whom it's directed or to the whole panel.
It's addressed primarily to Stan and Mr. Williams. I've worked in the Cleveland area for many years in mental health. I'm aware that the free clinic has done a fantastic job, but I'm thinking right now about the new Health Reform Act and how that might affect the free clinic and our hospitals. One, the requirements that it would cover many more people who today are uninsured, hopefully, and whether or not you're envisioning an increase in your population who would have the economic abilities now because of the reform. The other is the tremendous increase in Medicaid to our hospitals and our agencies. It's grown phenomenally, and it's anticipated that it will continue to increase. So I visited some agency recently which has something which they call expanding their boundaries. It's a social agency, but they're working very closely with Cleveland Clinic, with university hospitals, and where someone has a multiple problem, it's a mental health and a physical problem, they're able to get resources from these other resources who come in and work with them. So I'm wondering, Mr. Williams, at the free clinic, I know your population. There's something about the population, they're really outsiders, if I may call them that. they don't want to use the facilities that we have available oftentimes. They're not eligible, etc. But part of that is the problems that they are experiencing, which keeps them alien, so to speak, from our usual traditional health services. So how do you see the effects of the health reform and the possibilities that agencies see the increase in Medicaid monies, which will increase their capacities to serve more of the lower income population?
Well, first of all, Shannon promised me softball questions, so you raise a really interesting ethical dilemma for the free clinic. You probably know how we were founded. It was at a time 40 years ago. We're celebrating our 40th anniversary, and there are some very distinct aspects. It was a walk-in clinic. People often would line up for long lines outside the door. Episodic care. Often they'd come in and there'd be a one-time problem that could be dealt with, not in mental health areas so much, but often there were acute issues that they'd present with, and then they'd be gone. And sometimes a lot of the folks who came there were there because of the excesses of the 60s. There were drug problems, and there were STDs and all kinds of issues like that generally could be taken care of in a short period. But now, flash forward 40 years later, and the population is very different. And many of the people who come to see us suffer from a multitude of chronic conditions. Some you can still deal with. An extraction in a dental clinic, at one time, and maybe we don't see them back again. But many will present with 2 or 3 chronic conditions, and they're not as the same kind of outsiders. These are just regular old folks who either lost their job, 40% of the employers in this region don't offer their workers health insurance. So they may be working at a job and they just don't have access to buy insurance through their employer. So they're just like, folks who look like people in this audience. But to get to the heart of your question, it's forcing us to look at whether or not what the founding fathers had contemplated for the free clinic is still relevant in today's world, or should we adapt to what the needs are today. If we took a snapshot of the population of the patients at the free clinic now, our primary criteria is being uninsured. Right now, if the if the Medicaid expansion were in place right now, it went to 133% of Medicaid, 85 to 90% of the people who are coming to the free clinic now would be eligible for Medicaid. And if they signed up, they'd be ineligible to come to the free clinic. So you'd be faced with this interesting situation where you've got folks, many of whom you've had to work with for a couple of years to kind of get compliant, and they're trusting you, and then all of a sudden they get a way to pay, and you say, oh, you got to go. Now that you can pay us, you got to go. So we're looking at whether or not we need to adapt and change our business model to one that might accept some forms of insurance. Along with that would come a sliding fee scale. So how are you a free clinic if you're required to ask people to pay $5 a visit because you've then made it accessible? So there's some really tough ethical issues, but our board's looking at that now, and sometime in the next few months we're going to reach a conclusion about what we're going to do. But it's a tough ethical issue.
What about the health reform? How will that affect the clinic and other services?
Stan, would you care to comment on whether any sense of the health care bill reform?
Well, I don't think it'll make any difference at all to what we do, because our statistics, and we keep very good figures, show that 88% of the people that come to a RAM event are between the ages of 29 and 64. And after 64, of course, they're on got Medicare, and up until the age of 29, they're soldiering along on the fact that up until the age of 18, they were getting some type of state or federal assistance and care. We only see 6.6% children historically, but that number actually has dropped dramatically in the last 2 years, and now it's only around 2 and 3%. But only, I think, 0.1% of the population have dental insurance. And very few people, I don't know what the statistic is, have vision insurance and the ability to obtain eyeglasses. So, as I said earlier, either during this discussion or prior to it, a show of hands with 550 people, everybody wants the dentist, and a show of hands of the same group, everybody wants the eye doctor, and only 3 people stick their hand up, want to see a medical doctor. And yet they all need to see the medical doctor. So unless healthcare reform clearly addresses the problem of dental care for the masses, then the masses are still going to be at our events looking for it.
Well, if we could take the next question, Dr. Eastwood.
My question is to Mr. Brock. About 15 minutes ago, I think you said something like you do not engage in political activism to advocate for universal health care or anything else. And I think the inference was that you're busy engaged in doing the things you're doing, addressing the problem. Earlier today in Severance Hall, I thought I heard you say something like, although the majority of your activities are in the United States, you hope someday to be able to focus on those areas outside the United States that need RAM. And I thought the inference was that maybe the United States would address the problems. And I can't think of any other way in the United States of addressing the problems that you're facing so adequately, other than universal health care or its equivalent to universal health insurance. So those seem contradictory to me. Could you help resolve those? Let me just say, underneath all this is it seems like you are in a great position to advocate for changing the health system in the United States. That's the purpose of the question.
So it's difficult. Obviously, I have personal feelings about the whole thing, and I've appeared twice before congressional committees on this issue, and all I can tell them is what we see out there and what the need is, without saying, and I think you ought to have universal health care in this country. So I don't want to sort of go beyond that, really, because obviously there are shortcomings in the universal health care system. We're starting to get requests, mainly through the media in Britain, because they've all been over here. Why don't you bring the RAM program to the United Kingdom? And I had a telephone call from the editor of the Welsh national newspaper. He'd seen 60 Minutes. He said, if you brought over a group of dentists to the United Kingdom and brought them to Wales, he said there would be a queue, as he calls it, 1 mile around the block. And we had a similar comment from Scotland. So the universal health care obviously has shortcomings as well. People are not going into dentistry in the numbers that they used to, apparently. So there's a shortage of dentists. So is universal health care the answer? Maybe, maybe not. But I think you've got to do something for these people. I mean, for everyone that comes in absolute desperation to our clinic, how many hundreds of thousands must there be out there in a similar problem that are, as some people tell us, I took a pair of pliers to pull out my tooth, I mean, that's how we used to do them when I was a cowboy in the Amazon, right? Not even with a pair of pliers. It's just unacceptable in this country. But I don't want to, of course, get into any kind of political advocacy.
Professor Singham.
This question is addressed to Mr. Brock again. Part of the reason there's inertia to change in the U.S. is a lot of people think that what exists is really the best healthcare in the world. And that's largely because the kind of people you see and the kind of people you see in the free clinic are invisible to most of the population. Most people don't encounter them, so they think that what they've got is what most people have. When in your talk, you mentioned other countries like Haiti, Zimbabwe, and so on. I was wondering on what basis you selected countries and whether you waited for them to invite you or whether you looked at countries in need. And were there any surprises among the developing countries that you found that seemed to provide actually adequate health care or accessible health care to most people despite being developing countries that seem to provide accessible health care to most of their population despite being a poor country by U.S. standards?
Well, again, we only go where we're invited, and we have a lot of volunteers in our organization that are from places like India and Guatemala and other countries, and they encourage us to go there, and so the sort of request comes from them. But and take India, for example, where we go several times a year. There are incredibly talented doctors in India, and some of them volunteer with our organization. And yet there's still that extraordinary need out there because there's simply not enough of them to take care of it. None of the countries that we visit are able to handle the problem out there, particularly in the rural areas. But take Guyana, for instance, where we're there 365 days a year. If you live along the coastal belt, the chances are you can go to the Georgetown Public Hospital and have your problem taken care of free of charge. But if you live anywhere in the interior part of the country, the chances of you getting any health care are very, very, very remote. The government simply doesn't have the resources to be able to, put people out there in clinics to any great extent, and they certainly don't have airplanes to be able to go to all of these remote airstrips around the country to pick up the casualties, so to speak.
Well, I just want to give you the heads up. We are going to go until 4 o'clock, so we've got 2 questions waiting. We'll have to stop after those 2 questions. And please, ma'am, if you could address your...
I'm going to speak without the microphone, and if you cannot hear me, then you can stop me. I am Dr. Schultz.
I think they need it for the recording system.
There's no system. I don't usually speak into a microphone.
Oh,
I don't hear to. I am addressing this question to 2 of your panelists. The gentleman who I think is going to become political, or is political because he's going to run for something, or is running for something? Okay, yeah. And a gentleman who I have a great deal of probably akin with, because my degree is from Case Western Reserve. Dr. Snyder knows this. My friends have laughed and said, you were so bad they closed the department after you left, the day after you left, and they did, and it was the Department of Education. But I still have a PhD, which means I am a doctor. And we had a very wise and wonderful woman advising us, and she said, as each of us sort of popped up and defended our dissertation and went on, she said, don't wait for the call to the emergency room, because you shouldn't be there. I have had lots of surgeries at the Cleveland Clinic. I have an implanted heart valve. So I'm very aware of if you're someplace and you can't get help. And my question, but also a response to you, sir, who I missed. Sorry, I missed what I thought I was coming through this afternoon. I am dyslexic, and I got it twisted up. I wanted to hear over there, but since I was early enough to come to this symposium, I did. You mentioned Washington. I had some experience in Washington, as I had a daughter who also is dyslexic, and she decided to go off to school in the 9th grade. And I felt, no, that's too young. And so, fine, she went, and I bought a home in Washington, D.C., actually Georgetown. And that worked out very well, and she, that her education's fine. But she came back to finish at American University, having been in Switzerland for the first 2 years. And she had a dog who truly was her protection, because several times she was broken in. I know, but I realize I am aware of time too.
Okay.
But she was broken into, and so had the police and all. And the dog was her protector, and I had told her, don't put food in the shed behind this little teeny house. And she did. And I literally went down, and it looked like Ho Chi Minh Trail. There were so many rats going through there, you couldn't believe it. And I called the police, and I said, what do I do? Oh, he said, listen, lady, we see so many kids with their face bit off. Just cool it. And so I can understand why, you were not wanted there. And it makes me sick. And this was a number of years ago, so, And my question to you, which I'll follow up, is are you running for that office that is going to be very responsible for leadership in Cleveland?
Well, this isn't really. I'm running for County Council in District 10.
Okay, thank you. But it was politically right. They didn't want him there.
Yeah. Politics intruded on his desire to do good.
But here were people living in the district, not even in Washington, could not get the help that they really needed. And that's sad. That's sad.
Final questioner behind you. It's all of us. Please.
I'm intrigued with the idea of making ethical decisions within the arena that you're having to work. What I'm thinking of is, at least, I don't mean it literally, but it reminded me a person sitting in this chair having all of their teeth pulled. Well, my dentist tries to preserve as many of my teeth as that dentist can. And there are expedient ways to handle medical issues that will do a good job. We'll take care of the problem. But there are now technologies and ways of managing these problems that take now time, multiple visits. So how do you go about? It seems like this is an arena for making ethical decisions when you're dealing with poverty and people who you'll only see once a year. How do you make decisions on which treatments to use?
Very, very good question. We do a great deal of restorative dentistry. We do not extract any teeth that can be saved. But perhaps Dr. John Osborne, who's dealt with this for many, many years with us, you want to answer that question, John?
John, would you be willing to step up to the mic for us? This is Dr. John Osborne, who is a dentist who has volunteered with RAM for 20-odd years.
Yeah, one of the things that we try and do when we're in that situation is explain to the patient that there are other options. And a lot of times they come back and they say, well, there aren't other options for me. So you're here. If you can take out that tooth and get me out of pain, I'd appreciate it. There aren't, people can't always go to their dentist and have a root canal and a crown or multiple. And so we give them the options, but when it's the only alternative for them, we take out the tooth.
Well, ladies and gentlemen, I would like to give each panelist one last chance to make any additional comments, and then we are going to close this event. I would like to start actually over here with Mr. Williams. Is there anything else you'd like to comment about?
The only thing I would say is that Mr. Brock's work has been an inspiration to a number of people. I mean, both I can speak locally. There's an organization called MedWorks that was a direct result of having spent some time with you, traveling down to see your work there, and then they came back and sort of like Johnny Appleseed, they started a similar organization here. What we do at the National Association of Free Clinics, again, was directly inspired by your work. We all may do it slightly differently because we may work in different environments, but I think that in addition to what you've been doing individually, I think you should feel proud that you've inspired so many others who are looking at what you're doing and trying to adapt it to their environment. So we appreciate your contribution.
Dr. Hyun.
Well, my last statement is really a question directed at Mr. Brock.
Cheater.
I'll put my question. So when you think about what it is that you do you think you're going beyond the call of duty, or are you just doing your moral duty? And however you answer this, you come out looking great, by the way. I was just wondering, which of the two is it?
No bad answer to that.
Yeah, right.
You know, it came out of necessity. It came out of self-preservation 50, 60 years ago when I was so badly smashed up, and they said the nearest doctor is 26 days on foot from here. That was the inspiration. Well, let's try and see if we can't bring these doctors a little bit closer. But now, we've been doing this for so long, it has become such a large organization that unless it becomes, as I hope it will, in my lifetime, in the short time I have left, I hope that it becomes unnecessary for us to hold these events here in the United States, so we can concentrate in places like Haiti and the rest of the world. So until that time, we'll just keep doing what we're doing, and we've had over 46,000 volunteers, like John Osborne there, and we can't do it without volunteers. Basically, all I do is, you know, answer the phone, make a few arrangements, carry the luggage, but the medical work is done by people like John Osborne back there.
Professor Berg.
I guess my final comment would be to come off of Insu's point. I think you hold us up to a very high standard, but one of the things I so appreciate in having looked at your website and your comments is that you've pointed out that it's very small things can also make a difference, as you said a couple of times. The $5 and $10 donations make a difference, and in your website you pointed out to people that it can be small amounts of time donation that can also make a difference, and I think that is part of why we honor you today, but also what's so nice about the standard that you set for us and holding us to a very, very high standard of what you've done, but in pointing out that we don't have to meet that standard in order to feel that we can contribute.
Well, on that excellent note, I would like us all to thank our panelists and our guests. Stan, would you like to make another comment?
Well, again, I want to thank the Inamori Foundation. People came all the way from Tokyo, Kyoto, Japan. A miserable flight on an airplane, I must. And it is such an honor and a privilege to have you folks here, and you've got a wonderful program. And thanks very much indeed. It's a great honor to have you here, and we're most grateful.
Thank you, Stan. Thank you all.